go to
Carry
the
on.
next?
Carry
Okay.
on.
Carry on, please. Next case, Dr. Imam,
Yeah.
for
Thank
shock
you,
with
Dr.
the
Musa. I'll
combination.
present now a case with combined using ECMO with Impella in a patient with cardiogenic shock. I have no disclosure related to these presentations. I'll try to go over through the indications, the physiology, how to maintain these post devices in the patients, how we wean from this Impella, and if there is any evidence behind using both devices. This is a male patient, 56-year-old diabetic, presented with 2-hour chest pain, diagnosed as non-STEMI. He referred to me with intra-aortic balloon from local area hospital because there is no cath lab in this hospital, on inotropic support and ejection fraction 25%. This is the patient coronary angiography. As you can see, very diseased coronaries. RCA is occluded distally, left main, LED proximally, very bad flow in the distal LED. So I go directly and I did complex PCI left main LED Kilot technique, and I ended with, I think, acceptable results so far in this situation. But unfortunately, I sent the patient to the CCU with intra-aortic balloon. Few hours later, they called me, patient had VT, VF arrest. CPR was started, and we inserted the ECMO bedside in the CCU. And of course, I shifted back the patients to the cath lab. And this is what I had in the cath lab: complete occlusion of my stents, both stents. So I redo PCI. I managed to balloon the stents, and I get with this flow, and immediately I inserted Impella CP in a hand with the ECMO. So I inserted the Impella in this situation for the hypothesis of unloading the left ventricle, and we have some other mechanism of unloading left ventricle. It's not only the Impella. We have pharmacological and we have mechanical. Pharmacological, we can put the patient on inotropes and vasodilators, not vasopressors, vasodilators. We need to give away or give some breath for the left ventricle, so not vasopressors. Mechanical intra-aortic balloon, which is the least power to give to the patient. Impella and Lava ECMO, which is the cannula transseptal from left atrial and right atrium as well. But in our center, usually we put the patients in Impella to unload the left ventricle, and there is some flow charts from the mechanical circulatory support in cardiogenic shock. It's many, just to see the patient, and this charts give the indication of unloading the ventricle. If you put the patient in ECMO and left ventricle become distended or increasing, and the aortic valve is not opening, patient developed pulmonary edema, no LV ejection, there is a smoke shadow in the ventricle, and this patient, he has a very or a good recovery potential, so this patient should be unloaded by Impella, for example. So this is the indication of putting the patients on Impella with ECMO to be Impella. We have two types of circuits, ECMO circuits, as you know, all know. We have central, but we are speaking here about the peripheral VA ECMO because this is the primary approach in emergency. And this is the strategy when it combines with Impella, it's become Impella, because the central VA ECMO is a different story. So from now and then, I'm speaking about peripheral VA ECMO. This is the diagram showing us the circulation in the VA ECMO. Blood is drained from the left atrium, the blue arrow down, and get back to the aorta, but in a retrograde manner that's increased the afterload. And there is an antegrade pulsatile flow from the failing heart. And this post flow from the aorta, there is a mixing point, or we call it a watershed points, where the two flow are met in the aorta. So this is the idea of unloading the left ventricle, because the flow from ECMO is coming as a retrograde into the aorta, so that's increasing the load from already failed ventricle. And this can cause many problems. It can causes more decreased contractility of left ventricle, pulmonary edema, pulmonary hemorrhage, LV thrombus, whatever. It can very, very disadvantages. And as you can see here from our patients, the aorta is not opening at all. A patient already in ECMO. So don't wait until the LV failed. It is too late to unload the already failed ventricle. And this is another pigtail injection I did like 5 days ago, and you can see how the flow is stagnant in the aorta. This patient already on ECMO, and you can see how the flow is stagnant and it's not moving in the aorta, so we need also to unload this ventricle. The physiology of Ecpella, it's due to the BV lobe. I'm not going to the BV lobe here, but this is the normal one. Cardiogenic shock, it shifted to the right, and with ECMO, it shifted to more right. So the action of Ecpella, it takes the BV loop back to the left, so the Impella actually, it reverses the loading effect for ECMO, giving a time for the left ventricle to breathe and recover. What is the advantages of using Ecpella? It's effective for LV unloading, increase mean arterial pressure, increase coronary perfusion, decrease pulmonary wedge pressure, and improve RV after load. And the good things about Impella and ECMO, you can titrate the flow, because with Impella is unloading. Its job, it's only to unload the left ventricle, and ECMO is the main support for the patient. So you can play with the flow of ECMO and Impella just to get the best flow for the patient. But don't forget, now we are using 2 MCS. There is too many disadvantages, and there is too many problems just to keep an eye in. Bleeding, hemolysis, limb ischemia, stroke, systemic emboli. So it's not without a cost using 2 MCS. But if we can minimize this complication and this downside of MCS, maybe we can get more benefits from Ecpella. Weaning plan is very important. Also, it's referred to the indication why we put the patients on Ecpella. Either it's bridge to decision, or bridge to recovery, or bridge to transplantation and LVAD. So usually in like 99% of the cases, we used to wean ECMO first, then Impella. And I think from my previous case, we go through the hemodynamics and the parameters for MCS weaning, like PABI, cardiac power output, lactate, so echo, of course. So this is the parameters to put a plan for weaning from MCS. So in this patients, we after improvement in the hemodynamics and cardiogenic shock parameters, we removed Impella CP, and we put him on Impella 5.5 surgically implanted. Then we removed the ECMO, and we keep him for a time in Impella 5.5. Then we remove the Impella 5.5 and discharge the patients home after 55 days from admission. Do we have any evidence behind the Ecpella? There is some cohort study and experience center. There is no randomized controlled trial, and all or most of these studies, they suggest that Ecpella is associated even with improved survival with refractory cardiogenic shock. But there is more complication, of course, with using Ecpella versus ECMO alone. The complication is more. Randomized controlled trial or RCT are required to confirm these findings. So in summary, in cardiogenic shock, ECMO may cause LV distension. The heart usually is like a hole, is a big thing. that compromise myocardial recovery. Direct LV unloading by Impella was associated with lower mortality in the patient with cardiogenic shock, supported with VA ECMO in the recent trials and studies. In Impella, we need to remember that ECMO is the primary support for the patients. No need for high P level in the Impella. We don't want this flow to fight with the ECMO. And thank you very much.
Thank you very much.